This podcast is sponsored by PAX. Whether on water, on land or in the air, PAX bags are both versatile and flexible backpacks that are perfectly suitable for your requirements in the most demanding of environments. PAX bags are highly regarded due to their exceptional performance in pre-hospital and in critical care environments. Renowned for their durability, they endure harsh conditions while providing rapid and reliable access to essential kit. So their well-organised compartments and customisable configurations enhance efficiency in high-stress situations. PAX bags are designed with infection control in mind and are easy to clean and disinfect. Their highly visible colours and reflective strips add quick identification and adherence to quality standards, assuring reliability. The versatility of PAX bags caters to a diverse EMS providers, but also delivers vital equipment and durability and ease of use for pre-hospital critical care services globally. I've used PAX bags in a number of critical care situations and they're absolutely excellent. Please see the show notes for further details. So on the podcast, we're just about to start with a question time over the next few weeks and months. And this is really about getting your questions in to the podcasting team. So between 4 to 5 of us, we'll gather every month or other month to really answer your questions as a listener group. So please do head to the show notes where you'll find a Prehospital Care Podcast email. Do feel free to email us in your questions. And what we'll do is answer them between us as hosts. We'll do some research and background and contact all the different various guests we've had on the podcast and indeed other guests to get to you the best answers we can to some of your questions. So please do head to the show notes to the Prehospital Care Podcast email you'll find there and email us in your questions. This podcast is now live on YouTube, so please feel free to head over to the link in the show notes to watch this podcast or indeed this interview on YouTube and watch the interaction with the guests and feel free to rate and review and indeed subscribe to the YouTube channel. So please just head over to the show notes and you can find the interview on YouTube. Many thanks.
You're listening to the Pre-Hospital Care Podcast on the Medics Academy Network.
Welcome back to the Prehospital Care Podcast. In this conversation, we're going to be examining the percentage, growth and interest of females within pre-hospital emergency medicine. We also wanted to examine the diversity within the UK context and indeed how this has slowly but surely grown and affected the workforce for the better within pre-hospital care. We also wanted to discuss the hierarchy of competence, barriers to entry and some of the covert challenges that women have faced to enter PHEM. So to do this, I have Ffyon Davies with me. Ffyon is an emergency medicine registrar and an expedition doctor with a special interest in PHEM. She's also a World Extreme Medicine faculty member and an avid explorer. Welcome to the podcast, Ffyon.
Thank you for inviting me, Erin. Happy to be here.
I just wonder if we could just first kick off with getting you to speak to how you found your organic journey into PHEM. And was it sort of well publicized, clearly defined when you started? How was it for you?
I guess when I really think back, I probably had more of an interest in PHEM before I had a proper interest in emergency medicine. I started off my journey before even medical school volunteering for St. John's Ambulance. And that's where I think I really started getting interested in that sort of environment. I tried to continue it through medical school, various sort of ambulance ride out shifts and sort of student selected components that I did, many of which was self-organized. But then I guess I don't think I was super clear on the pathway into PHEM until I sort of met somebody who was doing it. And that was when I was a junior doctor as an FY1. And I met a registrar who'd gone and done PHEM training. And then she gave a fantastic talk about why the title of the talk was actually why she hated flying in the back of helicopters and trying to do medicine in the back of helicopters. And of course, that's kind of attention grabbing. And she talked about all the difficulties and challenges that go with PHEM. And that's where I kind of really started setting my sights on it as a career path.
That's interesting, actually, because like you said, it kind of lends itself to, it shows me a little bit of your personality, actually, that you like challenge and that you want to kind of set yourself a formidable challenge, because PHEM is challenging. Pre-hospital emergency medicine has many challenges. And I suppose my next question would be around sort of the meld and the mix of expedition medicine and how you've pulled it through to pre-hospital emergency medicine, because you saw the challenge within FEM. You've also done a lot of expedition medicine. How did the two sort of align?
I think again, like I liked mountains before I liked medicine. And so I was always trying to sort of find a way to combine those two. Um, the same with FEM sort of thing. But I think what I really struggled with as a junior doctor was that I was desperate to try and combine these things, but everybody sort of keeps telling you to focus on competence first. You know, you have to actually know your stuff, be a good doctor, and be confident working in a pre-hospital or expedition environment before you go off and do it, which is very frustrating when you're trying to start out and get experience, etc. Um, but I guess I started trying to do that, to build competence. So I sort of got some experience in critical care and in emergency medicine. And likewise on the expedition side of things, I went and did my mountain leader training because I thought, first of all, rule number one, don't become a liability on the mountain. So I went off and did that, and then uh, started applying for jobs in expedition medicine first of all, and was COVID sort of derailed things a little bit for me, but then eventually did get some expedition jobs after that, and managed to start building up some experience. And then following on from that, I think expedition probably helped me get a job in FEM, when I got a fellowship job in North Wales, working with the Welsh Air Ambulance up there, which was really a sort of probably a 4-year plan that I'd had in my head before I got to that point. And everything that I've been doing so far had led up to that point of kind of achieving that goal of getting a job on the helicopter, which I'd probably realistically wanted since I was about 16.
So let's go straight into just the main topic, really, or some of the main fundamental topics, Fionn, just around some of the barriers to entry for women into FEM from your perspective, either from your anecdotal experience or some of sort of the meta themes that you've seen within practice.
Big barriers to entry are multimodal or multifactorial. So it was a while before I kind of knew what the career pathway was. And it was also a while before I actually found a role model of somebody who was in my specialty, who was out there doing it, and who was a woman who was doing it as well. So I think that kind of it felt quite far away and quite alien until I actually met someone who was out there doing it. So finding those role models, especially when there's not many women in FEM, can be quite challenging. I think the other thing now, looking back and sort of where I'm at in my life as well, looking forwards, I think that getting into FEM and actually balancing it would be really tough if you've got childcare responsibilities. So I think looking back at the conversations that I had with colleagues whilst we were on shift, it was a big, big balance and sacrifice, and they had to have very supportive partners as well to facilitate them to be able to go and do the voluntary stuff that you have to go and do before you even get a job in FEM. You don't even get a look in really if you don't go to the charity days, go and do the ride out shifts, go and do the volunteer sort of stuff. So if you've got caring responsibilities, that's probably not really feasible for you. So then when you're actually in the job, the shifts are 12 hours mostly, which is pretty, again, challenging in terms of childcare. And yeah, it does make it more difficult. And I think FEM's not traditionally been particularly flexible or accommodating for people who, I've deliberately not used women who look after kids because that's not always the case anymore, is it? There's always a shared burden between sort of men and women in terms of looking after the kids. So yeah, looking forwards, that's kind of a struggle that I'm looking at the moment, is how on earth am I going to be able to balance that? For doctors as well, there's the difficulty of you're applying to a training program where you could be rotated anywhere in the country to get to do your FEM training. So that has additional stresses of you're going to have to travel. You could be potentially traveling 3-4 hours to go and do your FEM shifts. You may have to stay overnight, and it's time away from your support network, your family, your friends, your kids, etc. So yeah, there's a lot of difficulties actually and things to think about, and it kind of has to come at the right time in your career, I think, as well.
Listen, I would fundamentally agree with that. And I having worked in the UK and internationally as well, looking at some of the shifts, especially in more of the rural services which do critical care, maybe across British Columbia or across different provinces. a 12-hour shift can turn into a 16 or 18-hour shift, sometimes even a 20-hour shift if you get a late critical care transfer. And as you said, trying to organize childcare with that actually doesn't stop at 12 hours, but that can go to 20 hours, and having that flexibility is hugely challenging for some of the colleagues I interacted with in Canada and elsewhere. And not knowing, it's the not knowing piece which is really difficult, I think, as well. So it's a hugely important point you make. And you've spoken about inspirational people in your life, or indeed this inspirational talk. Were there any other fundamentally inspirational women that you found when you were either doing the role as a flight doctor, or indeed otherwise, that you kind of that became a mentor to you in that space?
Yeah, so the lady I talked about who I heard give a talk on this, she was my registrar when I was a junior doctor. I think my registrar, she was mine, she was no one else's. But no, she works in the same department as me, and I really, really rated her. She was a very, very high quality clinician. And I sort of quizzed her about her FEM experience and how she got into it. And then she mentioned that there was this fellowship job in a nearby hospital. So that was kind of where I set my sights on that and went to go and do that. But she was my clinical supervisor. She qualified as a consultant, and then she became my clinical supervisor when I was in that job. And she's a FEM clinician in North Wales. She's been a massive influence in my sort of FEM journey, from telling me to say no to more stuff, telling me to focus on this rather than that, and sort of career advice, life advice. Gosh, I think she would probably cringe to hear that, but I think it's true. And yeah, and I've watched her go on to have a kid of her own and sort of go through those struggles. So I think that's probably where some of those insights into childcare is starting to come from. And you know, so she's been a huge influence. And then I think there's a couple of other people I can think of, but not many really. I think in terms of inspirational female figures in FEM, there's really not many to look for. So I think that's actually one of the major issues, is that it's a struggle to see yourself doing something that you don't see anybody else like you doing.
Yeah, listen, I agree, and I think mentors are hugely important, be it male or female. But I think from an aspirational perspective, and like you said, putting yourself in the shoes, say, well, listen, if they can do it, I can do it too. And I think that it's super important to have that diversity and have that gender mix. Which leads me on to the next question quite nicely, actually, Fiona, around sort of how important diversity is within prehospital care in general. Could you maybe speak to some of the fundamental importance of having that gender mix?
Yeah, I guess the diversity I think is incredibly important. And I've maybe got some slightly unfounded, unevidence-based opinions about this, which is that actually I think diversity contributes to competence. That I think that having a diversity within the team actually allows the kind of non-technical skills, the things like the decision making, the communication, I think sometimes facilitates it to work much better. I don't think that is, necessarily always the case, but I think if you look at sort of maybe all female teams and all male teams and their sort of performance in the same scenario, they achieve the same things, but sometimes in very different ways. When then you look at a mixed team, I think that you get a little bit more sort of leveling out. I think there's maybe less ego around. Sometimes there is a little bit of how do I say this? Let's say in an all blokes team, there is often men just have this way of communicating with each other. They don't even have to say it; it just kind of happens. They can kind of just anticipate what each other want next. You ever watched a group of men try and build flat pack furniture? This just happens. There's instructions are not needed. You watch a group of women try and build flat pack furniture. Somebody's got the list. Somebody's going through the 1, 2, 3, 4, 5. This is what we need next. It's a screw that looks like this, etc. And there's maybe quite clearly allocated task roles. You're going to be the equipment equipment person, you're going to be hammering this in, you're going to be reading the list, etc. And there's probably a lot more talking that happens rather than like an all male team. I think if you intermix those, you probably get a little bit of the best of both. I think most of the time. I think there is some evidence emerging as well that women, certainly in general surgery, have better outcomes for their patients than male surgeons. So I think that is yet to be explored within PHEM, but I think would be really interesting to look at whether having diversity within teams actually contributes to performance and ultimately better outcomes for patients.
It would be super interesting, like you said, to have more empirical research on that actually, Fionn. So kind of going there really and looking at competence versus diversity. What's your thoughts on sort of should competence take precedence over diversity?
I think it's a loaded question, but I think no. Competence has always got to take precedence, in my opinion. We've always got to put the patients first, and so nobody would ever. So first of all, I would never want to be appointed to a job because I'm a woman. I want to be appointed to the job because I'm good enough to be there. So first of all, competence has got to be there, I think. But that doesn't mean that we can't do more to encourage diversity. And I think diversity maybe feeds into competence, but that is a step down the line. I think first of all, we have to look at getting the right people and the competent people into the job first.
Yeah, absolutely. So just looking at some of the highlights from PHEM that is given to you, could you maybe speak to some of the indeed kind of things you feel that you brought to the specialism as a female, as a woman, that like you said, kind of maybe would have been missing otherwise, and indeed sort of have brought that balance you spoke to before, that kind of gender mix, which maybe balances out other kind of non-mixed teams.
I think it's really hard to tease out what I think I've brought to it because I've never been in the third person watching myself in a team, if you know what I mean. So it's hard to try and compare my experiences personally to sort of in general, what's different when I'm in the team versus when I'm not in the team. Um, I would hope that I'm a very junior member of the team if I am in a sort of fem team. So I would hope I'm bringing enthusiasm. I would hope I'm bringing sort of motivation and a bit of drive. I'm really keen to be there. I really want to learn. And I think maybe that gives me a little bit of leeway in asking the stupid questions. Very happy to be that person. Which I think maybe contributes to some more open communication in general. Because maybe by me being the person who's willing to ask the stupid question, that maybe opens up the floor for other people to be able to contribute and maybe ask questions they may not otherwise feel confident to do. But of course, that depends on how it's received. So maybe that's something of what I've potentially brought to it. I think since I actually finished the job in North Wales and I sort of moved on, I've had a couple of opportunities to be involved in sort of FEM careers panels or I think a HEMS workshop at one point as well. And I think one of the most powerful things I've got from it is other people being able to ask me and see me in that position. And it just feels completely surreal because I'm now the person that people are looking at as a role model. Which doesn't help the old imposter syndrome because it just doesn't feel like that is where I should be. But to be able to see people actually envisioning and like planning their careers and actually where I was, when I really needed somebody to look up to and as a role model. And that's, I think, the biggest thing that maybe I've brought back to it rather than clinical contributions.
No, absolutely, absolutely. But we're just looking, Sophia, I'm just looking at how we increase diversity within FEM, because like you said, the attribution or indeed the experience from yourself was that you saw an inspirational female give this talk, woman give this talk, and who became your mentor. How do we attract more women into the discipline?
You put them on the front pages. You put them in the social media posts, you interview them, you put them up there with the men. There's a lot of this was really highlighted in the recent talk I heard from a CCP in, I think she's Devon Air Ambulance, and she's done a master's looking at women in PHEM and what are the sort of challenges and barriers, etc. And she showed a whole bunch of pictures from various air ambulance charities with a token woman in the picture, and it's sort of the wheeled out woman to come and tick the diversity box, etc. It's just not the way to go. And I think a lot of helicopter charities also like to portray that they're sort of big, strong, muscular, come save the day hero type people, which generally are not their women. They're generally their sort of young, fit, handsome, muscly men is the image that they want to put across. So I think she also mentioned she had a daughter who said who said something along the lines of, "Oh no, I can't work on the helicopters because I'm a girl." So that's really interesting to hear. That's a sort of child perspective, that they're not seeing it, that they're not seeing that women can be helicopter, clinicians as well. So I think putting them on the front page and putting them out there and the sort of promoting awareness of it is kind of probably one of the first steps. And then I think making it a tiny bit more friendly towards some of the caring responsibilities that many women will have to shoulder with their kids, etc. So there's some recommendations that's come out of this this masters that the CCP has done, which are, I think one of them, for example, is have childcare facilities on site at base, have like a little creche or something like that, which would make a big difference, I think, to a lot of people. I think that's probably the major thing for me is putting the people out there, making the role models known, and making it more accessible, but without detracting from the overall sort of quality of clinicians.
No, absolutely. And that exposure into, like you said, multimodal media is absolutely a way that we can aspire to, like you said, to motivate more females into the space when there's that portrayal in the media. Certainly one of my fundamental mentors, and I would never mind mentioning this, was Anne Weaver, Dr. Anne Weaver in London HEMS, and she was just one of the most key figures in my sort of PHEM experience, really, and really brought me through from in a leadership perspective, but also a technical perspective, and everything in between, from debrief, attention to detail, having the intimate knowledge of the equipment, and again, like I said, she led with compassion, but was strong on the back end of it, so that if she disagreed with something, she was not afraid to absolutely launch you out of the room. If you but not that wasn't the first, that was not the first character attribute that you came into interaction with it. And she would, I absolutely respected her, as did many others, and she has and is a great ambassador for women in PHEM. But just looking at the empirical evidence, actually, Ffyon, because we've spoken about this kind of the attribution of male-female environments and having this mix. But just looking at the empirical literature, could you maybe speak to what it says about women in PHEM, if indeed there is much on this topic at all?
I think if we're talking about the sort of non-technical aspects of performance, there isn't any literature that looks at femme in PHEM, or women in PHEM. I think that there is in other areas, but there's not much. There's the study I mentioned about looking at female surgeons, and they have sort of overall better outcomes, decreased length of stay for their patients, decreased complications and levels of infection in their post-surgical patients as well. So that starts to begin to say that perhaps there is a difference. And I think there is probably a little bit of controversy around researching men versus female performance statistics, because I think it can be quite divisive. But actually, I think it needs to be framed in the right way, that is about like, okay, well, what is it that women are doing in order to achieve these performance measures? What are they doing differently? And like I sort of mentioned before, I think, generally men and women have got different ways of achieving things, and that is a massive generalization. But we generally get to the same goals, but there may be some tiny little details which add up in the end to actually better outcome measures. I think the literature's not there at the moment, so this is all just opinion based, really. But it would be really interesting to see this studied framed in the right way, I think.
So just looking at something you said before about childcare, which is, like you said, it's a massive consideration, but can be shared between both partners. But it just, I guess my question is, what are some of the main factors that prevent continuity of females in FEM? Would childcare be sort of the main or sole attribution, or is there any other factors?
Yeah, I think it probably is ultimately around that sort of home stresses and other sort of responsibilities that they may have to be balancing as well as their job in FEM. Like I said, I think it's all the little things that add up, like the commute. How far are they having to travel to get there? Are they rotating around the country in a FEM training scheme, or I think ultimately as well, a lot of the jobs in FEM are actually, fixed contracts. They are 1 year, 2 year jobs. They're not permanent jobs. And you really have to fight to get in and to stay in, sort of thing. In terms of preventing continuity, I don't think it's it could be the clinical aspect. I was just going to say I don't think it is, but actually it's a tough job. It's a really tough job. There's some really horrible things that people see. And I think there probably does get to an element of people have just seen enough and they would just like to step away from that. So that definitely could be a factor, as well as the sort of pulls and responsibilities of family life as well.
Yeah, I would agree with that. I would absolutely agree with that. And I think it's sometimes a season and or it's definitely a path which can give to you and add to you, but there's sometimes a time cap, I think, from a longevity perspective around exposure and, like you said, antisocial element of the work as well. And but yeah, again, like diverse exposure to medical and acute trauma pathology, which is sometimes has a finite cap, has an endpoint in sight. Certainly within my own practice, it was good to step away from critical care for a while and actually focus on other aspects of work. So I absolutely agree with you, Ffyon. So just as we come into land on the conversation, could you maybe speak to some of the more recent strategies that you have seen instituted within the NHS and or otherwise to attract women into FEM, and indeed whether that's been effective from your perspective?
I think it's actually quite a tough question to answer because I don't think there has been a lot of strategies implemented within the NHS, certainly. I think in general, obviously I come from a more medical background, but in general, we've been moving a bit more towards less than full-time working and more flexible working, which is a step in the right direction because I think potentially a lot of the reasons that we struggle to retain doctors in the NHS are maybe slightly translatable in some ways to within FEM or attracting people to FEM in the first place as well. So less than full-time working and that kind of flexible working strategy is certainly making it more attractive. I don't think that attracting doctors certainly to apply for FEM is an issue. I think that there is interest there. And they are very competitive places to get into a FEM training scheme. There are not very many of them, and I think you will have to work extremely hard to get there. I certainly know people who've applied several times and either have had placements in unfeasible places that they've got I know a particular friend of mine, he based in North Wales, but was allocated training position in Scotland, and he's got 3 young kids. And so there's just no way he can do that. So he's had to say no multiple times to a spot on a training scheme for FEM, to the point where he's actually, this is a he actually, he's actually just given up on it. It's just too hard. You just can't do it. So yeah, there's certainly that competitive element of it. Whereas, there might be, let's say somebody ST4 or 5 in emergency medicine training who's got no responsibilities, living their carefree, fantastic bachelor lifestyle, who's quite happy to move to Scotland for a year. That's not a problem. They'll get that job. Yeah, so in terms of strategies, less than full-time working is definitely a good thing to make it a bit more feasible in terms of childcare and, other responsibilities, etc. And I don't think attracting women to the specialties is the issue. There is interest there. It's actually making it a viable job plan, a viable career pathway, and sort of keeping them in it as they progress through their own sort of personal lives as well. I think there's a lot of nervousness about coming back to work after maternity as well, particularly FEM jobs, because they're so high acuity and they're so high consequence if you get it wrong. So I think there's a lot of nervousness of if you've been off for a year. It's a rapidly progressing field. How much have you missed? How much are you out of practice? That would be certainly quite a concern if I was coming back after a year of not practicing. And that potentially just means that people think, do you know what, I'll just leave it. I won't go back to that part of my job. I'll go back to being an emergency medicine doctor, or maybe go back to being on the road as a paramedic or something like that. So I think that's certainly a sort of barrier as well, but maybe things like returning to work schemes, or sort of job familiarity days, or ride out shifts, or all of that stuff to kind of help people feel more in touch, or study days, or I don't know, some sort of program of getting people up to speed on latest evidence, that sort of thing. I think it just needs to be thought about. I think the reasons that people are leaving specialty, not staying in the specialty, need to be sort of positively identified, because I'm not sure that we actually know at the moment. There's a lot of conjecture, but not a lot of evidence. And then we can really start to put in place the strategies to help retain women within FEM. Like I said, I think the attraction is there. I think there's interest. I think we need to put the role models out there to say, yes, look, it's possible. Here they are. There's people doing it. And then the strategies in place to help retain and keep those people in FEM as well.
Listen, Ffyon, that's fantastic, and it's really interesting just to get your perspectives and thoughts on this. And I absolutely agree. I think what I've seen some of my colleagues within critical care, the longevity is in job share, and that's from an acuity perspective, but also, like you said, from the disruption to home life and indeed family life. That if that's limited to maybe a job share to 50% or otherwise, that they can then still have a semblance of continuity and consistency within a home life whilst doing 2 shifts or 1 shift a week, and still sort of keeping their hand in. And I've seen a lot of colleagues over 15, 20, 25, 30 years, the way that they move towards, or indeed stay within critical care, is almost retreating from that 100%, because then they can go into education, go into training, go into governance, or other kind of leadership roles, still keep their hand in, but kind of almost limit the damage, or limit the intrusion into family life. So I absolutely agree with you on that point.
I think just on that as well, I think particularly for CCPs within FEM as well, it's such a sort of fairly new, fairly evolving specialty, that the career pathway doesn't have a definite endpoint, and it doesn't have a definite progression. You get to a sort of band, I think it's band 8 you can get up to, correct me if I'm wrong. And then what? There's kind of a bit of a ceiling, isn't there, at the moment? That there's not a definite kind of step off point. You kind of get a little bit stuck up there, I think, which is yet to kind of resolve itself. But that's definitely another issue for people as well, that it kind of has a shelf life on it, a career in FEM at the moment, I think, when you get to that ceiling.
Yeah, I would agree. I would agree. And actually sometimes it's healthy to step away. It's an entirely different podcast around attrition rates and just when it's right to step away from critical care, maybe even full time. But it's super interesting. And like you say, it's a really young profession still, and has got lots of development yet to come. But and definitely the attribution and getting more females within FEM, I think, is something which needs to be a priority, to increase that gender mix and to increase the levels of, like you said, this demand, but the spaces and indeed the opportunities need to become, I think, a lot more diverse as well. Ffyon, what we'll do is I'll include the study you mentioned within the show notes, from general surgery. Like you said, I think the empirical evidence is sparse, but we will include whatever is pre-existing right now. And I just want to thank you for your time.
Thanks very much for having me. It's been a great conversation.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.